Hello everybody. Today we are going to discuss ammonia in critical care. So why serum ammonia increases with the liver failure? The liver is paramount for the ammonia metabolism during balanced homeostasis. So ammonia, that is NH4, or ammonium, that is NH3, reaches the liver mainly through the portal vein. 50% from the endogenous glutamine conversion into enterocytes and 50% from the gut lumen by degradation of nitrogen substrate from the diet or bacteria. In the hepatocyte, ammonia is converted to the urea or glutamine. Other organs like brain, kidney, muscles also participate in the ammonia metabolism. The kidney do not produce, not only produce from endogenous glutamine, but also excrete ammonia in the urine. With liver failure, the loss of viable hepatocyte leads to the impaired metabolism of ammonia. Therefore, these patients often develop hyperammonia. How increased serum ammonia affects the liver failure patient? So, hyperammonemia is the fundamental driver of hepatic encephalopathy. Its accumulation in the astrocytes, among other molecules, may lead to cerebral edema, intracranial hypertension, and brainstem herniation. Besides its neurotoxicity, hyperammonemia may contribute to immune dysfunction and infection, which is a common trigger of multi-organ dysfunction in this patient. So, which differences in ammonia metabolism are there between acute liver failure and acute and chronic liver failure patient? So, liver cell death is often greater and faster in acute liver failure than in acute and chronic liver failure. Therefore, serum ammonia frequently reaches higher level in ALF than in ACL. Brain osmotic compensatory mechanism are more evolved in acute on chronic liver failure than in ALF patients. Kidney dysfunction, both common in ALF and ACLF, and sarcopenia are more common in ACLF than ALF, also contribute to hyperemia. So, what is diagnostic and prognostic value of serum ammonemia in liver failure patient? In ALF patient, hyperammonemia, that is, arterial ammonia level of more than 150 has been associated with increased risk of major cerebral complication, including hepatic encephalopathy, cerebral edema, intracranial hypertension, and mortality. In ACLF patient, the risk of cerebral edema is lower than in ALF patient. Hyperammonemia has been associated with increased risk of extrahepatic organ failure and mortality. Now, the next question is, how should we measure serum ammonia in ICU? Serum ammonia level may vary with protein intake, brain, and muscle, uptake, kidney dysfunction, infection, or gastrointestinal bleeding. So, arterial ammonemia better reflects acute changes in nitrogen metabolism than venous ammonia. So, the upper limit of normal serum ammonia level ranges frequently from 50 to 70. Fresh blood samples are preferred to the frozen. Serial arterial ammonia measurement may be more informative than time-specific single determination. Normal serum ammonia level have shown higher negative predictive value for hepatic encephalopathy. So, which is the therapeutic strategies are there to modulate serum ammonia? So, one is laxative. Non-absorbable disaccharide, that lactulose and the lactulol, remain the first line option for hepatic encephalopathy treatment and prevention in cirrhosis patients. So, lactulose mechanism of action are multiple. Colonic acidification promoting conversion of NH3 to non-absorbable NH4. Inhibition of aminogenic bacteria growth. Inhibition of intestinal glutamine absorption and reduction of ammonia absorption time and increase in fecal nitrogen excretion. Other laxative, that is polyethylene glycol, have also improved hepatic encephalopathy. Now the next agent is rifaximin. Rifaximin is the non-absorbable gut-selective oral antibiotic recommended as an adjunct hepatic encephalopathy treatment in cirrhosis patients. Its mechanism of action are several, like suppression of microbiome or oralization and mucin degrading bacteria. Promotion of augmented response to pathogens and gut barrier repair, and reduction of serum pro-inflammatory cytokine level and infection. Now metabolic scavenger. Like L-ornithine, L-aspartate, that is LOLA, may reduce serum ammonia by promoting conversion of ammonia to urea in the liver. Additionally, ammonia may be further converted to glutamine in the liver and in skeletal muscle. LOLA may be safe and effective in hepatic encephalopathy treatment and prevention in cirrhosis patients. However, LOLA did not seem to improve serum ammonia and hepatic encephalopathy in ALF patients. So, L-ornithine and L-phenylacetate may reduce serum ammonia by promoting its renal excretion as phenylacetyl glutamate. Although its safety profile has been tested both in cirrhosis and ALF patient, its effect on hepatic encephalopathy remain unclear. Now about extracorporeal circulation. Ammonia is small, that is 17 kilodalton, which is a water-soluble molecule with low volume of distribution and minimal protein binding. Although ammonia resembles urea, its dialysis clearance is 30 to 50% of ureas. About renal replacement therapy during intermittent hemodialysis, higher blood flow and dialysate rate and dialyzer surface were associated with higher ammonia, glutamine, and urea clearance. In ALF patient on continuous renal replacement therapy, higher effluent flow rate, greater cumulative dose were associated with higher ammonia clearance. There was no difference in ammonia clearance between different CRRT modalities. Absorptive filters like cytosol auxiliaries have not led to effective ammonia clearance. So overall, CRRT results in greater ammonia clearance than IHD since it is deployed for 24-hour period. In ALF patients, CRRT had shown to be associated with better survival and IHD has been associated with worse survival. So potentially IHD may lead to more often to hemodynamic derangement. While CRRT initiated early and extended for longer time may be an useful adjunctive hyperammonemia treatment in ALF patients that remain unclear in ACLF patients. About life support dialysis, among several liver support dialysis devices developed, Prometheus and Mars have been mostly studied. However, their impact on ALF and ACLF patients' outcome remain unclear. While Prometheus has higher urea clearance than Mars, that was not as significant for ammonia. About plasma exchange in ALF patient, whether high, that is 8 to 12 liter, or standard, that is 1.5 to 2 times of plasma volume, has decreased serum ammonia level at least as efficiently as CRT. Potentially similar data for ACLF is lacking. Now, practice implication and future direction. In liver failure patients, especially in those sedated, serum ammonia monitoring may anticipate the risk of brain complication. The use of laxatives or rifaximin may be hindered by ILS. Third, CRRT constitute a safe and effective strategy for hyperammonemia control, especially in ALF patients. Future studies, both ALF and ACLF patients, could explore hyperammonemia as an independent indication for CRRT initiation. So, moreover, novel treatment with serum ammonia lowering potential, such as fecal microbiota transplantation, still require further validation. Thank you, guys.